Hello student. Now we are going to quickly revise two small topics. One is general physiology and one is GIT. So first we are starting with general physiology. So what are the important things that you have to revise before your exam? So first you look at one MCQ. So this MCQ has been asked in NEET 2021 examination, and I will say this is one of the most simplest MCQ asked so far. So in this question, they are asking that the electrolyte measurement of an fluid component is sodium 10 milliequivalent per liter and potassium 140 milliequivalent per liter. Looking at this electrolyte composition, you have to identify, and I'm 100% sure all of you know that it is nothing but intracellular fluid component which has a higher potassium concentration near around 140 milliequivalent per liter and low sodium concentration. Sodium concentration is high in the extracellular fluid, so that if the sodium concentration is very high, like 145 equal, that is indicating that is the extracellular fluid. So you just have to remember that this electrolyte composition of this ECF and ICF, so this is the ECF component and this is the ICF component. You can find out that the sodium and potassium, they are strikingly different between these two components. Sodium is very high in the ECF and potassium is very high in the ICF. Apart from that, you also have to note down here that the calcium concentration between ECF and ICF, look at this. So the calcium concentration, if you look carefully, you will be finding out that this is one of the electrolyte where ECF is to ICF concentration ratio is very high, tremendously high. Look at outside calcium concentration is 2.4 milliequivalent per liter and inside is 0.001 milliequivalent per liter. It is said that the ratio between ECF is to ICF calcium is in and around 12,000 to 20,000 is to 1, right? So this is one electrolyte where ECF is to ICF concentration or ratio is maximum 12,000 is to 1. Apart from that, also note down that the protein concentration is very little in the extracellular fluid, but in comparison to that, protein concentration is very high in the intracellular fluid. All of you know that the protein is a large molecule, so it is impermeable to the cell membrane, and whenever one impermeable molecule like protein is present in one of the compartment, it will exert one effect, and that effect is known as the Donan effect, right? So Donan effect, right? So this question has already been asked, that Donan effect is due to which of the following? So your answer will be large impermeable molecule like protein, right? So these are the things that you have to remember. Now moving on to the next question. So here question is baroreceptor reflex is an example of. So again you see that this is a NEET 2022 questions and one of the easiest question, right? So here we all know that it is a negative feedback reflex. Okay, so this question is based on the physiology which is known as the control system in biology. So control system, all of you know that there is feedback control system, right? And there is feed forward control system, feed forward control system. So this feedback control system again are of two types. One is negative feedback control system and one is positive feedback control system. So we have to remember the examples of this positive feedback control system, that is important for our MCQ, and for this negative feedback control system, most of the biological system is an example of negative feedback control system. Like for here, the baroreceptor reflex, whenever your blood pressure is rising to a high value, okay, it will activate the baroreceptor, and the activation of the baroreceptor will inhibit the sympathetic system, and that inhibition of the sympathetic system will leads to again decrease in blood pressure. So what is happening whenever your blood pressure is rising? Blood pressure is decreased by baroreceptor control system. It is a typical example of negative feedback control system. So now look at the positive feedback control system and this feed forward control system. They are more important for MCQ. So the positive feedback control system, all the examples has been written here. Okay, so first one is the process occurs during blood clotting. All of you know that the activation of one clotting factor leads to activation of the subsequent clotting factor. Like for example, remember whenever there is generation of a little bit of thrombin, this thrombin can activate the factor number 5, factor number 8, and many other factors. So this is a typical example of positive feedback control system, because of which the clot formation become very easier. Second, the LH surge. All of you know that the LH surge gives estrogen gives a positive feedback on LH, and because of which LH level become very high, which is responsible for ovulation. The third one, the uterine contraction during the process of childbirth, that is also an example of positive feedback reflexes. This is also known as Ferguson reflexes. Then lactation during the suckling of the baby, that's also gives a positive feedback control system, which leads to more and more ejection of milk. Number 5, generation of the action potential. Here you have to look at very carefully. During the generation of the action potential, there is opening of the sodium channel, voltage gated sodium channel, as well as there is opening of the voltage gated potassium channel. We know that opening of the voltage gated sodium channel leads to depolarization. This is a typical example of the positive feedback control system. But opening of the potassium channel leads to repolarization of the action potential, and the opening of the one potassium channel leads to inhibition of the subsequent potassium channel. So this is an example of negative feedback control system. So please note down that whenever I am saying that during generation of the action potential, the positive feedback response is only during the depolarization. During the repolarization, or more specifically opening of the potassium channel, is an example of negative feedback rather than positive feedback. And the point number 6 is opening of ryanodine receptor for the release of calcium. You know that whenever there is entry of little amount of calcium in the cytoplasm, that calcium stimulates the ryanodine receptor. Further calcium will be released in the cytoplasm, and that calcium will again stimulate further opening of the ryanodine receptor channel. So this way, all of these are example of positive feedback control system. You have to remember this, right? Now, apart from positive feedback, the more important thing is that you have to understand what is gain of the control system and what is feed forward control system. So now look at gain of the control system. Just remember, for quick revision, that gain is equal to correction upon error. So this is the formula, correction upon error, right? So what is the meaning of this? Suppose one question has been given like this, that when a person is changing his posture from supine to standing posture, what will happen to the blood pressure of the subject? You all know that whenever the person is changing his posture from supine to standing posture, the blood pressure will drop down. Now suppose the question is saying that during this changing in posture, there is dropping of 10 millimeter of mercury blood pressure. So blood pressure decrease how much? 10 millimeter of mercury. Now due to the inhibition of the baroreceptor system, now the baroreceptor will try to correct this blood pressure. And how much correction? So correction is around 8 millimeter of mercury. So there is drop of 10 millimeter of mercury blood pressure, and the baroreceptor system is correcting it. And how much correction has been done? 8 millimeter of mercury. So I can understand that this correction is not foolproof, because still there is some error which is persisting in the system. That is nothing but 2 millimeter of mercury. So 10 millimeter drop, 8 millimeter correction, error is still 2 millimeter of mercury. So with the help of this formula, I can understand that correction is 8 millimeter of mercury and error still remaining is 2 millimeter of mercury. So the gain of this control system is 4. So in this example, I can understand that the gain is correction upon error. If I use this formula, then here the gain of the baroreceptor control system is 4. Getting my point? And the correction is happening in which direction? So the disturbance is occurring in the downward direction and the correction is happening in the opposite direction. So that's why you can say that this gain is negative gain or positive gain. Obviously this is a negative gain. Always remember that normally the gain of the baroreceptor control system is in and around 2, right? Thermoreceptor control system has more gain, in and around 33.5, right? But you have to remember that in a control system, if the residual error is 0, suppose one control system is foolproof control system, that whenever there is disturbance, the control system is capable of correcting that disturbance to 100%. Means no residual error is there. Error is 0. So in these cases, if you calculate the gain of the control system, so correction is full correction and the error is absolute 0. So what is the gain? The gain is infinity. So please remember that there was a MCQ in NEET entrance examination that infinity gain is seen in which organ system in our body? Your answer will be the infinity gain example is kidney. So kidney can correct your blood pressure and blood volume with zero residual error, provided you give enough time. That means kidney is a part of the long-term regulation of our blood pressure control system. So if you give enough time for maybe for months or weeks, so what it will do, the kidney can control your blood pressure. It can correct your blood pressure to 100% with zero residual error. So that's why kidney for the correction of the blood pressure and the correction of the blood volume. These are the two examples where residual error is zero and gain of the control system is infinity. So these are the important thing that you have to remember for your MCQ purpose. Now you look at the examples of feed forward control system. So what is feed forward control system? All of you know that feed forward control system is nothing but it is an anticipatory control system. So whenever your control system is expecting some kind of disturbance, he is correcting, he is taking some measure so that the disturbance will not affect the system. Means you are taking some precautionary measure so that whenever the error is going to happen, before that you have taken some measure. That is a kind of system which is known as feed forward control system. Look at the example, thermoregulation system. You know that body always try to maintain the core body temperature. Whenever your skin temperature is drop, okay, thermoregulatory system try to raise the body temperature ahead of the fall of core body temperature, so that it is an example of feed forward control system. Thermoregulation has two parts. One is feedback control system. So feedback is also there as well as feed forward is also there. But mainly it is the feed forward control system. It try to raise the body temperature ahead of fall. Which body temperature is more important? The core body temperature maintenance is more important. Getting my point? Yes. Second thing, increase in heart rate and respiratory rate even before the start of exercise. This has been asked in MCQ. That suppose I ask you that you have to do the exercise on this treadmill for the next 1 hour. So whenever you are thinking that you have to start the exercise, this anticipation that you have to start the exercise will start rising your heart rate and respiratory rate. This is known as the psychic stimulation. Okay, psychic stimulation. Your brain has understood that you have to start the exercise and he is rising the heart rate and respiratory rate in anticipation. So feed forward control system. Cephalic phase of gastric secretion. So all of you know that whenever you are looking at some food, or suppose you are chewing the food, so food has not yet entered into the stomach, but stomach is secreting acids in anticipation that food is going to reach. So this is again a typical example of feed forward control system. Receptive relaxation of the stomach. You know that whenever food enter in the upper part of the esophagus, the upper part of the stomach dilate ahead of food. So food is not entering into the stomach, it is only in the upper part of the esophagus, but stomach is dilating itself in anticipation that food is going to come. He has to accommodate, right? And the cerebellum. So the granular cell stimulate the basket cell and basket cell inhibit the Purkinje cell. So basket cell mediating inhibition of Purkinje cell. This is in control of feed forward control system. In my detailed lecture, I have discussed this thing detail, but for the time being, you just remember these are the examples of feed forward control system in our body, right? So this is all about the control system and the feedback, the gain of the system. Now coming to the body water. So what you have to read in case of body water. So look at first two MCQs. One question, the question looks similar. First question is ECF is dash percentage of total body water, and in second question ECF is dash percentage of total body weight. So don't think that the answer of these two questions will be same. So to answer this question, first you look at, I hope all of you know that this distribution of the body water, how it is distributed. So the total body water, how you are going to get the total body water? You take the 60% of your body weight. So if a person has a body weight of 70 kg, so you take 60% of 70 kg, that is the 42 liter. So the 42 liter is the amount of the total body water in that person who has a body weight of 70 kg. Now this 42 liter water will be distributed in 2/3. That means 28 liter will be in the ICF and 14 liter will be in the ECF. So this is the way we calculate the body water approximately. So same thing has been written here. So the 2/3 is the ICF and 1/3 in the ECF. But look at another things I have also written here, that this is 40% of the body weight and this is 20% of the body weight. So if I ask you that ECF is how much percentage of your body weight, your answer is 20%. But if I ask you ECF is how much percentage of your body water, then your answer is 1/3 of the total body water. 1/3 means how much percentage? 1/3 means 33%. So this 1/3 means this is 1/3 of total body water. This 2/3 means this is 2/3 of total body water. But whenever I am writing this percentage means percentage of the total body weight. So if the question is ECF is how much percentage of body water, your answer is 1/3 percentage means 33%. But how much percentage of body weight? It is 20%. So in the second question, it is 20% is the answer, and here it is the 33% is the answer. Getting my point? So please be careful. Similarly, if you look at the ECF has been divided into two compartments, interstitial fluid and plasma. So if I ask you, plasma is how much percentage of ECF? Then it is 1/4 of ECF. 1/4 means it is 25% of ECF. But if I ask you directly that plasma is how much percentage of your total body weight, then it is 5% of the total body weight. Getting my point? Same way, interstitial fluid is 15% of the total body weight, but it is the 3/4 or 75% of ECF. So this way, this is very simple, but sometimes MCQ can be a little bit tricky from this topic. So body water distribution, you have to remember like this, right? Now the next is how this body water is calculated by some mathematical equation. Look at the question here. So this question has been asked in AIMS entrance examination. Here the question is 100 milligram of sucrose is injected in a 70 kg man. The plasma level of sucrose after mixing. So plasma concentration is given, as well as it is also said that 5 milligram has been metabolized during this period. So how to calculate this? You know that this calculation is based on a principle. That principle is known as volume of distribution principle. Volume of distribution principle. This is very common topic and question has been asked multiple times. So what is volume of distribution principle? Look at. So this is the representative diagram. So this is nothing but the capillary, and these are nothing but the cells of our body. Okay, so these are nothing but the cells. So in volume of distribution principle, first of all, you have to inject one substances into your venous blood. Suppose I have injected Q milligram of substances. Okay, then what will happen? Depending on the property of these substances may penetrate through this capillary blood or may not. But suppose I am assuming that the substances is easily penetrable through the capillary. So it will penetrate through the capillary wall and it will reach in the interstitial fluid. After reaching into the interstitial fluid, it will try to cross the plasma membrane also. But suppose the substances that I have injected here, he is not able to cross the plasma membrane. So what will happen? So the substances will be distributed only in the interstitial fluid, and obviously it will be also distributed in the plasma, but it will not be able to distribute within the intracellular fluid or ICF. That means if I ask you, these substances, the Q milligram of substances that I have injected here, where it is distributed inside the blood vessels, as well as it is distributed inside the interstitial fluid. Means it has been distributed in the plasma as well as interstitial fluid. Combination of plasma and interstitial fluid is what? ECF. That means this Q milligram of substances has been distributed in the extracellular fluid. Now after proper distribution, you have to take a little blood sample from this person and you have to measure what is the concentration of these substances into this blood. Suppose this concentration is C, right? So now what you have to do, if you divide this Q upon C, then you are going to get a volume, and this volume is nothing but the volume of the fluid in which this substances has been distributed. Getting my point? So what you are getting? You are getting a volume. Volume of what? Volume of the fluid in which the substances has been distributed. Now, whenever you are injecting any substances into your blood, there is always a possibility that some portion of the substances may be metabolized or may be excreted by the blood. So that's why you have to take that into consideration. So the formula is actually, it is Q minus E. So what is this E? E stands for, it is the part which has been excreted or metabolized. So Q is the total amount of substances that you are injecting, E is the excreted or metabolized part, and C is the plasma concentration of the substances. This formula is the formula for calculating the volume of distribution. Looking at this formula, we can easily understand that different substances has to be used for measuring different fluid compartment. Answer is obviously yes. So if you want to measure only the blood volume, then you have to choose one substances which is impermeable to capillary. Otherwise, if it is permeable to capillary, then it will be distributed in the interstitial fluid also. So that way, different substances has to be used for measuring different compartment fluid volume. You have to remember one table where all these substances have been summarized. Look at, this is one of the important table that you have to remember for your MCQ. If you want to measure the total body water, the deuterium oxide, D2O, tritium oxide and antipyrine is used. If you want to measure only the ECF volume, the substances which has to be used is inulin, sucrose, sodium 22 isotope, iodine 125 iodothalmate, and mannitol. So these are the substances which is used for measuring ECF compartment. So if I want to measure ICF volume, you cannot measure ICF volume directly because there is no such substances which will be distributed only in the ICF, not in the other compartment. So what you have to do here, you have to measure the total body water and you have to measure the ECF separately and subtract them. You are going to get the volume of ICF. Similarly, if I ask you how to measure the plasma volume, your answer, the substances should be confined within the plasma only. It is impermeable to capillary. So those substances are Evan blue and 125 iodine, 125 tagged with albumin, right? So albumin tagged with iodine, sorry, right? Now, if you want to measure the interstitial fluid, again you have to measure the ECF separately and you have to measure the plasma volume separately and subtract them. You are going to get the interstitial fluid volume. Similarly, if you want to measure only the RBC, then this chromium isotope, iron isotope, okay, tagged RBC can be used for that purpose, right? Now we are looking back at this MCQ once again. So now we have to apply the formula. What formula? The volume of distribution formula. The V is equal to Q minus E upon C. So here Q is 100 milligram minus metabolized is 5 milligram and the plasma concentration is 0.01 milligram. That means this is 95 upon 0.01 ml. That is nothing but 9500 ml. 9500 ml is equal to 9.5 liter. What substances have been used here? Sucrose. Sucrose is used for measuring which fluid compartment? Sucrose is a disaccharide which is freely permeable to the capillary, but it is impermeable to the plasma membrane. So it will be distributed in the plasma as well as in the interstitial fluid. So basically this is nothing but measurement of the ECF volume in this person. Getting my point? So this is all about the fluid compartment and how to measure this fluid compartment. See here, sucrose has been written here, which is used for measuring ECF volume. But the best substances for ECF measurement is inulin, right? So these are the all things that you have to remember. Now look at the transport process across the cell membrane. Look at here. This is an interesting question and tricky question. So active transport across the cell membrane is mediated by, if you look at suddenly at this question, you will think that this is a very easy question, sodium, potassium, ATPase pump. True, it's an active transporter. But what about carrier protein? Can carrier protein be also used for active transport? Answer is yes, this is also a true statement. Now I have to choose in between these two, that both of them can be used for active transport. Now first of all, you look at active transport are mainly of two types. We know primary active transport and secondary active transport. So first of all, you look at this whole transport system process. So the transport process is divided into active transport and passive transport, and obviously endocytosis and exocytosis are also there. Now if you look at the active transport process, again it is divided into primary active transport and secondary active transport. Okay, and this secondary active transport is again divided into two parts here, that is symport and antiport. Now this symport, antiport, they are the part of the secondary active transport. They require the help of carrier protein. I hope you know what is the meaning of carrier protein. Carrier protein means is a protein which will binds with the substances, then the carrier protein will change its shape and then it will throw the substances into the other compartment. Right. Like for example, one carrier protein is transporting glucose. First it will attach with glucose. Then the carrier protein will change its shape and then the glucose will be extruded into the other part of the cell membrane. So that way the carrier protein functions. So if I ask you the symporter and antiporter, what are they? They are carrier protein. If I ask you sodium potassium ATPase pump, what is this? This is a protein. What kind of protein? Can it change its shape? Answer is yes. It also changes its shape for the transport of sodium and potassium. So basically, sodium potassium ATPase pump, it is also a carrier protein. Carrier protein can also be used for this facilitated diffusion. That means carrier protein can be used for active transport also, can be used for passive transport also. So look at here, this is taken from Guyton. So carrier protein, where they can be used for facilitated diffusion, they can be used for active transport process also. Getting my point? Active transport means which type of active transport? It can be used for primary active transport also, as well as the secondary active transport process also. So if I ask you that this question is asking active transport across the cell membrane, will you mark the sodium potassium ATPase pump or will you mark carrier protein? So sodium potassium ATPase pump only indicating this is the primary active transport, but carrier protein can be responsible for primary active transport also. It can be responsible for secondary active transport process also. So the better answer will be carrier protein. So this is an old MCQ of AIIMS entrance examination and all of the guidebook has been given correct answer that carrier protein is the best suitable answer in this question. Although sodium potassium ATPase pump is also an example of active transport process. We all know that. Right? Now, this is very, very important thing you have to remember. Now, also look at this passive transport process. Passive transport can be of osmosis, it can be of diffusion. And we know the diffusion can be of three types: simple diffusion without any carrier protein, facilitated diffusion with carrier protein, and non-ionic diffusion. Typical example of non-ionic diffusion is the what? Yes, secretion of ammonia at the level of kidney, at the level of GIT. They are the example of this non-ionic diffusion. Just remember this example. Now, simple diffusion and facilitated diffusion, if there is presence of a channel protein, then it's a simple diffusion. Look at here the diagram once again. So this is a channel protein, as you can find out here, and the channel protein has been put into which category? Simple diffusion. So the sodium is passing through the sodium channel. What is that? Simple diffusion only. Okay, because channel protein does not binds with the sodium. Okay, it does not binds with sodium like that of the carrier protein. Okay, so that's a channel protein. All channel proteins are example of simple diffusion only. Now, whenever we are talking about simple diffusion, you have to remember one important thing, that the calculation of the rate of simple diffusion, is done by a formula which is known as Fick's law of simple diffusion. This has been asked in MCQ. So the rate of simple diffusion can be calculated by Fick's law. What is Fick's law? According to Fick's law, simple diffusion rate, so this J is nothing but the rate of simple diffusion, is equal to D multiplied by A multiplied by delta C upon your X. So this D is the diffusion constant, right? So this D is the diffusion constant. A is the surface area of diffusion, that what is the total surface area through which diffusion is occurring. And this delta C is very, very important. Delta C is the concentration difference between two sides of the membrane. And X is the thickness of the membrane through which diffusion is occurring, right? So this formula you have to remember. This is known as Fick's law of simple diffusion. Now, based on this Fick's law, look at this MCQ. So in this MCQ, they are saying that the solution A and B, suppose this is solution A, suppose this is solution B, they are separated by a semi-permeable membrane, okay, that is permeable to urea. So in this question, the membrane is permeable to urea. Now the solution A contain a urea of 10 millimole. 10 millimole urea is there, and solution B contain urea of 5 millimole, right? 5 millimole or 5 mole, whatever, 5 millimole or 5 mole, whatever you say. So this is mole. Now they are saying if the concentration of the urea in solution A is double, so now you are changing this concentration to 20 millimole without changing the concentration of B, because they are not commenting on anything on B. So what will happen to the rate of diffusion? So urea is passing through the simple membrane, so it's a simple diffusion process. We just learned that simple diffusion rate J is calculated based on dA delta C upon X. So if every parameter is constant, so it is directly proportionate to delta C. So this J or rate of diffusion is directly proportionate to concentration difference between two sides of the membrane. So in the first cases, when it was 10 and 5, the delta C or the concentration difference between two compartments is 10 minus 5, that is 5. But whenever you have changed the concentration to 20, keeping the B concentration same, then here the delta C is 20 minus 5, that is 15. So because of the change in concentration, the diffusion has been increased from 5 to 15. That means 3 times increase in diffusion. So the question answer will be triple, right? It is not double. Although looking at the question, you are thinking that this is a very simple question, but not that much simple. Okay. So this is 3 times increment in diffusion, right? So next we are looking at another transporter dependent question, glucose transport in adipose tissue. So this is a typical memory based question. We all know that in adipose tissue and in muscle tissue, cardiac muscle as well as skeletal muscle, the glucose transporter is nothing but GLUT4, right? GLUT4. And we also know that GLUT4 is the insulin dependent GLUT, right? So this is important to remember. Now another question, the mechanism involved in the absorption of glucose from small intestine. Very, very important question. Very, very important question. So from the small intestine, whenever the question is like this, the absorption of glucose, they mean to say that absorption of glucose from luminal membrane of intestinal epithelium cell. But suppose the question has been asked that absorption of glucose from basolateral membrane of the intestinal epithelium cell, then the answer will be different. So in this question, the answer will be secondary active transport. Why secondary active transport? The absorption from luminal surface is done by SGLT1 and absorption from basolateral surface is done by GLUT, GLUT2. GLUT2 is an example of facilitated diffusion. Facilitated diffusion. So what I have to remember? I have to remember intestinal epithelium cell like this. Suppose this is the intestinal epithelium cell. Very, very important question I am telling you. From the luminal membrane, if they are asking question about glucose or galactose, both uses the same transporter, glucose and galactose. So whether it is glucose or it is galactose, it will take help of sodium and glucose or galactose will be transported, and this is known as SGLT1, right? But the main transporter for glucose transport at the level of kidney epithelium cell is SGLT2. I hope you remember that, right? So this is about glucose and galactose. But if the question is, what about fructose? That is also a monosaccharide, fructose. So transporter of fructose is nothing but GLUT, GLUT5. So if I ask you question on glucose and galactose, it is SGLT. All the SGLT are example of symporter. So it is nothing but secondary active transporter. But all the transporter which are started with the name GLUT, glucose transporter, they are example of facilitated diffusion. So please be careful. Now look at the basolateral aspect. On the basolateral membrane, whether it is glucose, whether it is galactose, or whether it is fructose. So whether it is fructose, glucose, or galactose, all are transported by GLUT2, and GLUT2 an example of what? GLUT2 an example of facilitated diffusion. Getting my point? So please be careful in this question. Very important. So now we can understand that there are GLUTs and there are SGLT. which could be a very, very potential MCQ. Answer is yes, obviously yes, right? So now look at in this table, all the SGLT and all the glutes has been put into, right? So first you look at SGLT, secondary active transport. SGLT1 is present in intestine, main, as well as it is also present in kidney, but in kidney which part? The proximal straight tubule. The second part of the last part of the proximal tubule is proximal straight tubule. But the main glucose transporter in kidney is SGLT2. It is said that SGLT2 is responsible for 90% of glucose transporter in kidney. So this is SGLT2, and 10% of glucose transport is done by SGLT1 in kidney. But in case of intestine, only on one SGLT is present, and that is SGLT1, right? Sometimes this SGLT3 can also be given in MCQ. It is particularly present in skeletal muscle, also little amount in small intestine, right? Now looking at the glute, so there are different glutes. You don't have to remember all of them. You just remember glute 1, glute 2 and glute 4 at least. Right. So glute 1, highest level is present in the RBC. So anytime it can be asked in MCQ. Glute 2, we all know that it is present in pancreatic beta cell. It is a glucose sensor for the pancreatic beta cell. Whenever your blood glucose is high, through this glucose transporter, the glucose will enter in the pancreatic beta cell. But this glute 4 is an insulin dependent glute. It is present in heart, skeletal muscle and adipose tissue. Very, 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 very important. But not only that, insulin dependent glute are also there apart from this glute 4. I'll tell you which one that. But before that, see here the glute 5. What is glute 5? Although the name is glute 5, it is an fructose transporter. It is transporter of fructose. This you also have to remember. Other glute you may go through, but they're not very important to revise just before exam, right? So before exam, you at least remember whatever is written on this slide. Insulin responsive glute, glute 4. We all know. Apart from that, glute 12 is also there. Insulin responsive glute in blastocyst, glute 8, right? So during the fetal development, during the blastocyst development. Fructose transporter glute, glute 5, we all know. Apart from that, glute 11 is also a fructose transporter. In central nervous system, there are 3 different types of glute. Glute 1 is present in the blood-brain barrier, endothelium cell of the brain capillary. Glute 3 is present in the neuronal membrane, and glute 3 is present on the astrocyte membrane. So you can understand that astrocyte is taking glucose through this glute 5, neuron is taking glucose through this glute 3, and how the glucose is entering into the brain fluid, that is by glute 1, that is the blood-brain barrier glute, okay? And the major glute in placenta and fetus is glute 1, right? So these are the important things that you must have to remember, okay, for your future MCQ, okay? Now moving ahead. So here, a research scholar, while studying the cell cytoskeleton, so you can understand that the question is on cell cytoskeleton. Now look at the description of the cell cytoskeleton, okay? It's a fibrous protein, right? And it is a stable stand. These are the 2 cues in this question. So it's a fibrous filament-like protein and it's a stable protein, stable stand of protein. You know that there are 3 main different types of cell cytoskeleton. We say that cell cytoskeleton are of 2 types. One is dynamic cell cytoskeleton and one is static cell cytoskeleton, right? Dynamic means the length of the cell cytoskeleton can alter, right? But static means this is the stable cell cytoskeleton. The length of this cytoskeleton is not going to change. The examples of stable cell cytoskeleton is intermediate filament. An example of this dynamic cell cytoskeleton is microtubule and microfilament. So just if you understand this one, your answer will be done. So that is intermediate filament. This is the question they are asking here, right? So intermediate filament, you know that this is a stable cytoskeleton. Stable cytoskeleton means it is not going to alter its length according to the cell growing. That's why this intermediate filament, they are used as a cell marker, cellular marker. You know what is the meaning of cell marker from your pathology knowledge. If you want to identify a particular type of cell, like for example, epithelial cell, The marker is cytokeratin. So what is this cytokeratin? The example of this intermediate filament is cytokeratin. So cytokeratin is a marker of epithelium cell. Cytokeratin is an intermediate filament. Like desmin, like vimentin, all of them are cell marker. Who are they? These are nothing but intermediate filament, fixed, stable structure within cell. Got it? So just quickly look at this three different types of cell cytoskeleton. Okay, microfilament, intermediate filament, microtubule. I told you already that this is dynamic one. Okay, this is also dynamic one, and this is the fixed cell cytoskeleton, stable cell cytoskeleton. Look at the diameter. Looking at the picture, you can easily understand that the microtubule is the strongest one with a huge diameter of 25 nanometer. Okay, and this microfilament is the thinnest one, 7 nanometer is the diameter. Now, sometimes they can also ask you what is the sub-unit of this cell cytoskeleton. Okay, so the tubulin is the subunit of microtubules and actin is the subunit of microfilament. Intermediate filament composed of various different types of protein like cytoskeleton, vimentin, desmin. Okay, so that's why it is written several protein in case of intermediate filament. So this is the most briefest thing that you have to remember in your general physiology. Now, after finishing quick general physiology, we are going to finish this GIT physiology, a quick revision. Okay, so in GIT physiology, the questions will be straightforward. They are going to ask you informative question mostly. Okay, so with that respect, we are going to quickly revise this GI physiology. So first topic in GI system that you have to read, must read before your exam is the basic electrical rhythm, means motility of the GIT you must have to read. So first an important thing is the basic electrical rhythm or the basal electrical rhythm. Look at the MCQ. List frequency of BER, basic electrical rhythm, is seen in which part of the GIT? So it's a memory based question. You have to remember what is the rate of basic electrical rhythm in different part of GIT. In this question, the answer will be stomach. Okay. And the maximum rate is at the level of duodenum, right? So you try to remember the rate of BER in different part. Here it is given. In case of stomach, this is 4 per minute. In case of cecum, 2 per minute. But cecum is not there in this option. In this question, the option is not there. So that's why we are choosing stomach. Okay. But look at the maximum rate is duodenum followed by jejunum, right? And the minimum rate is cecum. If that is not in the option, then stomach. And sigmoid colon, they have also asked directly what is the rate of BER at sigmoid colon. Your answer is 6 per minute. Now this BER, basic electrical rhythm, what is this? So please remember, BER is nothing but resting membrane potential of smooth muscle cells of GIT. Smooth muscle cells, BER is nothing but resting membrane potential of smooth muscle cell of GIT. What is that? The resting membrane potential of smooth muscle cell of GIT moves from minus 65 millivolt to minus 40 millivolt, means it's not a fixed voltage. The membrane voltage will drop down to minus 65 millivolt. Again, the membrane voltage will move to minus 40 millivolt. Again, it will drop down to minus 65 or minus 60 millivolt. Again, it will move to minus 40 millivolt. So this way, a rhythmic fluctuation of electrical voltage will continue in the smooth muscle of the GIT, and this rhythmic fluctuation of electrical activity is known as basic or basal electrical rhythm of GI smooth muscle. Got it? So this is nothing but BER is nothing but a resting membrane potential only, rhythmic fluctuation of the membrane voltage. Now question is, who is generating this kind of rhythmic fluctuation of membrane voltage? Why the membrane voltage is not fixed? Who is causing this fluctuation? You know that there is a pacemaker cell in the GIT which has also been asked in MCQ, and all of you know the name of this pacemaker. It is nothing but interstitial cells of Cajals, CAJAL, interstitial cells of Cajals. It is the pacemaker cell of GIT, and this Cajal cell is responsible for generating the basic electrical rhythm, right? Okay, first thing. Now you look at another MCQ related to this BER only. Okay, so conversion of BER to an increase in intestinal muscle tension. So muscle tension means the muscle is contracting and the muscle is producing some force. So first question that you have to think here, can BER produces muscle contraction? What is BER? BER is RMP. Can RMP causes muscle contraction? Answer is no, muscle contraction is possible by BER itself. For contraction of the muscle, you require action potential. So whenever the BER is generating action potential onto the top of it, then and then only the muscle contraction is going to happen. So what I'm saying like this, suppose the BER is going like this, okay, at a particular rhythm the BER is going, okay. So whenever this BER is moving above a certain voltage, that certain voltage is known as the threshold voltage. So whenever the BER is moving above a threshold voltage, then and then only action potential is going to fire. We all know the basic concept is that the RMP should go above the threshold voltage. So whenever the BER is moving above this threshold voltage, more positive than that of the threshold voltage also, what will happen? There will be development of few action potential, and this group of action potential which is developing on the top of the BER is known as the spike potential. So this spike potential is nothing but a kind of action potential only, group of action potential, and whenever there is generation of this spike potential, the smooth muscle is going to contract. So there will be contraction of muscle, and whenever there is contraction of the smooth muscle, what is going to happen? The tension in the GIT smooth muscle will be increased. So the question they are asking here, that what is the reason that the muscle is producing tension? What is the reason that this BER is going above this threshold voltage? Very valid question, that why the BER is suddenly going above the threshold voltage? Yet there must be some stimulus in the form of neurotransmitter, and the most important neurotransmitter is acetylcholine. So look at here, in this question the answer will be release of acetylcholine. Acetylcholine releases from parasympathetic system. All of you know that in presence of parasympathetic stimulation, there will be contraction of the GI smooth muscle. Your motility will be increased right there. Okay. So how the acetylcholine is causing increased contraction of the smooth muscle? This is the reason. In presence of acetylcholine, the BER will go above the threshold voltage, and whenever the BER is going above the threshold voltage, spike potential will be generated that will cause muscle contraction. Muscle contraction can be of peristalsis also, can be of segmentation also, can be of any other type of GI movement, right? But the basic thing is that acetylcholine is responsible for converting this BER into action potential. Got it? So please look at here. The activation of the interstitial cells of Cahals is only responsible for BER generation. Adrenergic discharge. In presence of adrenergic discharge, the BER will go below the threshold voltage. Okay, that's why we know that whenever you give sympathetic stimulation, adrenergic stimulation, GI smooth muscle will relax because BER will go down. Okay, it will go below the threshold voltage. But acetylcholine, the BER will go above the threshold voltage. Okay, so that's why the answer is here. The release of VIP also causes relaxation of the smooth muscle of the GIT. So that is not also my answer. Got it? So this is very, very important thing. Please note down. In GIT, one of the most important thing is BER, right? So next question, AIIMS 2015 question. So a small segment of mammalian small intestine was mounted over Dell's tissue bath. Don't have to worry about what is Dell's tissue bath. It's a apparatus which is used for study the movement of the GIT. So you take a small part of the GIT, you put that tissue onto this bath, you maintain the temperature of the fluid, you maintain the electrolyte of the fluid, and you study what is happening to the contraction or relaxation of that smooth muscle. That's all. So even if you don't know what is Dell's tissue bath, you don't have to worry. Look at the question. Movement was recorded. A substance was added at point X. Which of the following correspond to X? So look at here. There is a diagram which is given here. So contraction, relaxation, contraction, relaxation, contraction, relaxation of the smooth muscle of GIT. So this is basically not your BER. This is basically mechanical contraction and relaxation. So as you can understand that this y-axis is the strength of contraction. So strength of contraction is very high. But just after giving these substances X, you are finding out that the strength of contraction is decreasing further, and there is no contraction at all. So that way I can understand that this substance X is causing relaxation of the GI smooth muscle. So what will be the substances? Obviously this adrenaline. We have just understood that adrenaline means the BER will go below the threshold voltage. So the action potential will disappear, and if the action potential is not there, contraction of the GI smooth muscle is not going to happen. That's why there will be relaxation of the smooth muscle. So see, same concept, but the question has been given in a different way, but answer remains the same. Got it? Okay, very good. Now look at all other substances, acetylcholine, KCl, barium chloride, all of them will increase the strength of contraction like this. All of them can increase the strength of contraction like this. Okay, so relaxation is only done by adrenaline among these given choices. Fine. Okay, next question. So the next is, which of the following substances causes anterograde relaxation during peristalsis? Gut peristalsis. So here the question is not about the BER. Here the question is about another movement. Okay, that is the peristalsis. You know that in fed state, so when the food is there in the GIT, there are two movements mainly. One is segmentation movement, and another one is the peristaltic movement, peristalsis movement. But in between these two, if I ask you which one is the dominant motility during the fed state, your answer will be most common motility is segmentation. Dominant motility is segmentation. Okay. Peristalsis is not the dominant one. Although it looks like that peristalsis is the only motility, no. In fed state, major motility is segmentation. But whenever the question is about the fasting motility, so fasting motility means when there is no food in the GIT for last maybe 90 minutes, there will be another motility which is known as the migratory motor complex. I'm coming to this, right? So here the question is about peristalsis. They're asking which of the following substances causes anterograde relaxation during peristalsis. Very definite question, and this question has been asked multiple times. So what we have to remember? We have to remember that in peristalsis, whenever food bolus reaches at a particular part of the GIT, there will be stretching of that part. The stretching will lead to secretion of serotonin from the intestinal epithelium cell. This serotonin is going to act on the enteric nervous system. So whenever this enteric nervous system is activated, I hope all of you know what is enteric nervous system, the myenteric plexus and Meissner plexus, mainly the myenteric plexus. So this enteric nervous system will be activated, and this activation will occur in such a way that the neurons which are projecting in this proximal part, they are going to release substances acetylcholine and substance P, and the neuron we are projecting in the distal part or anterograde part, they are going to release the nitric oxide, BIP and adenosine triphosphate. In presence of substance P and acetylcholine, there will be contraction of the proximal segment of the GIT. In presence of NO, BIP and ATP, there will be relaxation of the distal part of the GIT, and because of this kind of scenario, the food will move in the forward direction, propulsive movement. That's why we say that peristalsis is the propulsive movement. So please note down, never forget this information, that proximal contraction is done by this and distal relaxation is done by nitric oxide, BIP and adenosine triphosphate. Okay? Right. Okay. Now next, another MCQ on this migratory motor complex. I told you that migratory motor complex is a fasting motility. The initiation as well as regulation of migratory motor complex is done by a hormone which is nothing but motilin. Please remember. So motilin is secreted from MO cell of duodenum jejunum, that is the small intestine, duodenum jejunum. It can be also released from stomach, but I have to remember the main is the duodenum jejunum and the second release site is the stomach. So MO cell releases motilin. Motilin causes initiation as well as regulation of migratory motor complex. I have to remember certain information about migratory motor complex also. So I told you it's a fasting motility. Why you require fasting motility? So there is no food in the GIT, but still the GIT is having some motility. Why? This is to clear the content of the GIT which is still remaining in different parts. Getting my point? So after the digestion and absorption of food, certain amount of food particles, certain amount of gastric juices, certain amount of intestinal juices may remain in the GIT. You have to squeeze out all that content. That means it is clearing the GIT. It is preparing the GIT for the next meal. That's why it is said that migratory motor complex is a housekeeping motility. It is maintaining some housekeeping function in the GIT, right? Okay. So the migratory motor complex starts from stomach and it ends at the level of ileum. Means MMC is not seen at the level of large gut. It starts from the middle part of the stomach and ends at the level of terminal ileum. I already told you that motilin is responsible for initiation and controlling of this motility, right? Now the speed of the MMC is 5 centimeter per minute, and MMC or migratory motor complex start only after 90 to 100 minutes after last food. Means you should do fasting at least 90 minutes. Not before that your MMC is going to start. MMC will start only after a period of 90 to 120 minutes from the last food. Got it? And the MMC will reappear. Means if there is starting of one MMC movement, second MMC will only start after an interval of 90 minutes. That is also important for your MCQ. So these are the information that you have to keep in your brain. Got it? Okay. Next MCQ. So next MCQ, let emptying of gastric content in the presence of hypertonic and acidic content in the duodenum. Look at the question, very specific. So this question is regarding the movement of the stomach. Okay. Due to presence of certain thing at the level of duodenum. So if there is certain kind of content, like for example hypertonic content or acidic content present at the level of duodenum, it hampers the movement of stomach. It decreases the movement of the stomach by a reflex pathway which is known as enterogastric reflex. Got it? So whenever huge osmolality containing food or hypertonic food or acidic food is present in the duodenum, from the duodenum a neural reflex will reach to the level of stomach, which will causes contraction of the pyloric sphincter and it will decrease the motility of the stomach. That is known as the enterogastric reflex. So basically we have to remember certain point about motility of the stomach, gastric motility, certain point we have to remember. So what are the point? The main pathway for regulating the motility of the stomach is the neural pathway, neural reflexes, vagovagal reflexes. It is the main reflex which control the motility of stomach or gastric emptying, right? Second, most rapidly emptying substances from stomach is isotonic saline. So suppose you have taken different types of food, or suppose you have taken different types of liquid. Which liquid will pass from stomach to duodenum in a rapidest fashion? The answer is isotonic saline. Regarding food, the first food which will move from stomach to duodenum is the carbohydrate, followed by protein, followed by fat. That's why, if you take huge amount of fatty food, it will remain in your stomach for long duration and you will feel heavy in your abdomen. Okay, all of us has felt this kind of scenario after taking heavy, rich meal, rich in fatty food. Got it? Okay. Now, second thing, distension of duodenum. Acidic content in the duodenum and high or low osmolality food in the duodenum hampers or decreases the emptying of the stomach. This is known as the enterogastric reflex, which we have already discussed in our MCQ. Okay. Apart from that, you also have to remember, so although the main pathway which controls the motility of the stomach is neural reflexes, but you also have to remember certain hormones can also regulate the emptying of the stomach, motility of the stomach. Who are they? Gastrin stimulate the emptying. Means if I ask you what is the role of gastrin on pyloric sphincter, it will cause relaxation of the pyloric sphincter. But the CCK, secretin gastric inhibitory peptide, GIP, they basically inhibit the pyloric sphincter. They basically prevent the emptying of the stomach. Got it? Okay, very good. Now next. So next topic in GIT, which is the second most important topic, is the GI hormones. Regarding GI hormone, at least you revise 3 hormones. Who are those 3 hormones? Gastrin, CCK, secretin. The most important thing that you have to read about these 3 hormones is what is the stimulus for the secretion of this hormone. Must know. Okay, so please note down that for gastrin, the most potent stimulus is peptide. Very, very important. Apart from that, distension of the stomach is also a stimulus. Calcium ion, if it is present in your food, it's also a stimulus for gastrin. GRP, gastrin releasing peptide, is also a stimulus. Where from this gastrin releasing peptide is coming? Parasympathetic system, which is stimulating the G cell, gastrin producing cell. It releases a neurotransmitter which is not acetylcholine. It is a GRP. So that's why we say that peptides is the most potent stimulus. Distension, calcium ion is also a stimulus, and GRP is also a stimulus. Carbohydrate has no effect. Important. Second, for CCK. CCK is released from the I cell of the small intestine. What is the most potent stimulus? Again, your answer is peptide is the most potent stimulus. Fatty acid is the second most potent stimulus, and carbohydrate has no effect for CCK secretion. For secretin, again, it is secreted from S cell which is present in the small intestine. Most potent stimulus. Acid is the most potent stimulus. Protein can also stimulate the secretion of secretin. Carbohydrate again has no role, and fat has minor role. So we can easily understand from all this discussion that carbohydrate has no role for secretion of whether it is gastrin, CCK or secretin. For gastrin and CCK, most potent stimulus is peptide. For secretin, the most potent stimulus is acid, okay, H plus ion. Now look at the function of all of them. So functions is not very important, but you remember the gastrin has main function for acid secretion from parietal cell of stomach, although it can stimulate the pepsin secretion from peptic cell of the stomach. CCK, the main function is increase in pancreatic enzyme secretion as well as gallbladder contraction. At least you remember these 2 functions. And secretin, very, very important. Look at, for CCK, we are saying that what is the main function of CCK? The main function is enzyme secretion from pancreas and gallbladder contraction. But for secretin, the main function is increase pancreatic bicarbonate secretion. Got it? So, both of them, CCK and secretin, both of them has effect on pancreas. But CCK has effect on pancreatic enzyme secretion, and secretin pancreatic bicarbonate secretion. Bicarbonate secreted from pancreatic duct. So this is the 2 important things that you have to remember. Now, apart from the functions of these 3 hormones, another 3 hormones, sometimes they are confusing if it is coming in the examination. That's why I have kept these 3 hormones. Okay, all of them are not hormone actually. So one is pancreatic polypeptide, one is peptide YY, and another one is neuropeptide Y. Why these 3? Because all of them are included in the same family. So they are in the same family peptide. But look at neuropeptide Y, it's a neurotransmitter in central nervous system and peripheral nervous system, and it's a potent stimulus for food intake. But look at the peptide YY, it is secreted from L cell of the distal ileum and large intestine, and it decreases the acid secretion and motility of the stomach. At least you remember this. So note down this important thing, peptide YY. This is known as ileal brake. So peptide YY is also known as ileal brake peptide. What is the meaning of that? So whenever fat containing food reaches at the level of this L cell of the distal small intestine, what will happen? It will releases the peptide YY, and peptide YY will causes inhibition of the motility of the stomach. So what is happening? So fatty food is reaching at the level of terminal ileum. From the terminal ileum, peptide YY is released and it is acting at the level of stomach to decrease the motility of the stomach. That means as if it is putting a brake at the level of stomach. That's why it is known as the ileal brake. That from the level of ileum, one peptide is released which is causing brake at the level of stomach. That's why this peptide is known as the ileal brake. Okay. Apart from that, this pancreatic polypeptide is secreted from pancreatic PP cell and it decreases the pancreatic bicarbonate secretion. So these are the important hormones that you have to remember in GIT. Now, apart from all of them, another important GI hormone is also there. Look at this MCQ. Which of the following substances is secreted in response to oral glucose load? So we have seen neither gastrin, CCK or secretin are stimulated by your glucose load or carbohydrate. So what is the GI peptide which is released in response to glucose load? Remember, the peptide is GIP. This is the only one GI hormone or only one GI peptide which is stimulated by all three different types of food. Carbohydrate is also a stimulus. Protein or peptide is also a stimulus for this peptide, and fatty food is also a stimulus for this peptide. So this GIP is one GI peptide which is stimulated by all three types of food. Now, what is the function of this GIP? This GIP is a peptide which has action at the level of pancreatic beta cell for the release of insulin. So what I'm saying? I'm saying that GIP is a peptide which is secreted from gastrointestinal tract, but the effect of this peptide is at the level of beta cell of the pancreas. This kind of peptide is known as incretin. So what is incretin? GI peptide acting at the level of beta cell of pancreas for the release of insulin. And we all know that most potent incretin is the GLP, glucagon-like peptide 1. But this GIP is also an example of incretin, right? That's why you know that previously the full name of the GIP was gastric inhibitory peptide, right? We all know gastric inhibitory peptide. But now the name has been changed. Now the name of this GIP is glucose dependent insulinotropic peptide. Getting my point? Okay. So this name has been changed to glucose dependent insulinotropic peptide, means it has tropic action on insulin secretion. Okay. And it's a peptide which is dependent on glucose load. Glucose load is a stimulus for this peptide. Got it? Very good. Now next question. Maximum contraction of gallbladder is seen with. All of you can answer that this is CCK. Any substances which causes contraction of the gallbladder is known as CHOLAGOGUE, cholagogues, right? So please remember, CCK is the most potent cholagogue. Second most potent is the fat. So cholagogue is the any substances which causes contraction of the gallbladder and release of bile. But there is a similar kind of question. Most potent stimulus for bile secretion. Any substances which stimulate the bile secretion at the level of liver. This is known as choleretics. CHOLERETIC. Choleretics. So choleretics are the substances which causes release of bile at the level of liver. Most potent choleretic is the bile salt, although bile acid is also a choleretics. Got it? So cholagogues, CCK, choleretics, bile salt. Just remember this. Okay. Now the last part of the GIT that you have to read a little bit is the GI secretion. So see, there are different glands in the GIT. All those glands are going to secrete various volumes of fluid, various composition. So I have to remember the secretion from stomach, pancreas, bile or intestinal. All of these secretions are isotonic in nature, isotonic in nature, but the salivary secretion is hypotonic in nature. First thing. Now, the volume of all of this secretion has been given here, but they are not very important for MCQ, but the pH of this different secretion is important for MCQ. So the most alkaline fluid which is secreted from pancreas, we all know the pH is H.3. The pH of the other secretion has also been given. So at least you remember the pancreatic secretion is the most alkaline and most acidic secretion is from stomach. Sometimes they directly ask what is the pH of salivary secretion, that is 6 to 7. Okay. Now, among all of this secretion, they also ask that maximum potassium is secreted from which secretion? Maximum potassium. So now this question, maximum potassium, has two parts. If they are asking that maximum potassium is secreted from which gland, then they are asking about the maximum amount of potassium secreted from which gland in one day. But whenever they are asking that maximum potassium concentration is present in which secretion, then the meaning is different. They are not total, they are not asking about the total load of potassium. They are asking what is the concentration of potassium. Okay, so maximum concentration, answer is colorectal fluid, colon and rectal secretion. Maximum amount of potassium is secreted by salivary secretion. So amount means per day, total amount of secretion. Got it? So please remember, this is very, very important for MCQ, has been asked multiple times. Apart from this, maximum sodium and least potassium is bile. Maximum potassium, least sodium is saliva, just opposite. Maximum bicarbonate, obviously in the pancreas, that's why the pH is very, very high. Okay, and maximum chloride at the level of stomach. So at least you remember this basic minimum from secretion. Now after secretion, the absorption, the maximum absorption from which part, what substances, that is also important. So look at whether the question is carbohydrate, protein or fat. The maximum absorptions occur from which part of the GIT? Answer is duodenum, not the jejunum. I am telling you in my main lecture, I have given you the reference also, but for the timing, you just revise that maximum carbohydrate, maximum protein, maximum lipid are absorbed from which part of the GIT? Duodenum, followed by jejunum. Similarly, maximum folic acid absorption, maximum iron absorption also occur from duodenum. But we all know that maximum bile salt and maximum vitamin B12 or cobalamin absorptions occur from which part? Ileum. Got it? Now coming to the water absorption from GIT. So total volume of water which is reaching at the level of GIT per day is 9 liter. Total amount of volume of fluid from different glands, from your drinking of water, total is 9 liter. Within this 9 liter, 8.8 liter of water is reabsorbed by different parts of GIT, and maximum water reabsorptions occur from which part? Jejunum, 5.5 liter per day, followed by ileum, followed by colon, and only 100 ml of water is excreted with stool. Got it? So this question has been asked already, that what is the total amount of water absorptions occur in the GIT? So approximate 8.8 liter. Okay, and what is the maximum absorption of water from which part of the GIT? That is from jejunum. So this is all about your GIT, what you have to read before your exam. So this finishes the quick summary of general physiology and GIT.